Good evening, dear colleagues. My name is Tariq Al-Tawil, and I'm a professor of orthopedics and traumatology at the National Institute of Neuromotor System in Cairo. My talk will be on scaphoid delayed union and non-union fixed with percutaneous headless compression screw. This is a quick presentation of the old traditional open autografting and the newer percutaneous fixation through dorsal approach, coming through clinical presentation. Abdullah is a 27-year-old male who had delayed union of fracture scaphoid, and this is obvious from the pre-op X-ray here. And what we did is a traditional way of taking an autograft from the volar aspect of the distal radius, was known by matchstick graft, and through the bed of the flexor carpi radialis, we expose the scaphoid, and actually whether you use an on-lay graft or inlay graft. I personally prefer the inlay graft. With a small curette, evacuate some of the bone from inside the two fragments of the graft on both sides, and gently separate them and insert this graft in between, and take some cancellous bone from the donor side and put it around the graft. And this is post-op X-ray, and you can see the site of where we took the graft, and maybe you may see the shadow of the graft of this. This is another case done through the same technique with autografting or the Rus graft. This is the donor side, and you can see the cortex content of the graft quite obvious, and the graft actually maintains the height of the scaphoid. And again, we take some cancellous bone, put it around the graft, and close the wound, and of course keep the arm in well fitting, well molded above elbow POP. This is the donation side graft, and you can see the union here, quite union, and the nice alignment of the scaphoid. And this is the man after, quite happy with the result. Definitely not full flexion, but quite satisfactory result almost. Very nice extension, pronation, and supination. I wanted you to share with me this 13 years old follow-up, 13 years follow-up. And this boy was 18 years when he came to me with non-union of the his scaphoid, and I did the same technique, took a graft from distal radius, and through the bed of the flexor carpi radialis, we inserted the graft gently between the two fragments, and you can see after 13 years, actually, the scaphoid looks quite nice, and he was quite happy with the result. The dorsal approach, it has been recently more popularized with some criticism regarding close proximity to important structures, namely the posterior interosseous nerve extensor digitorum communis to the index finger and the extensor indicis proprius. With careful dissection, this could be avoided. And the idea actually depends on flexing the wrist to 45 degrees, which will put the scaphoid in almost vertical position, and under image intensifier as we are going to see, you can pass the guide wire in the central axis of the bone, preferably, of course. This X-ray shows you that the scaphoid lies at 45 degrees to the longitudinal axis of the radius, and again on the lateral view also lies on 45 degrees. So if I flex this wrist 45 degrees, this scaphoid will lie almost vertical, and under image intensifier this will be easy for me or you to pass the guide wire directly down with more ease. This is actually a combined approach by the AO and the point of entry of the K-wire comes through the dorsal aspect. You can see the rest here is at 45 degrees, and the scaphoid will be almost looking down, and it's easy then to pass wire through a small incision, taking care not to avoid tendons or nerves. And then you pull the wire out and you pass the compression screw retrogradely in this situation. We didn't use this technique. While you pass the wire from the dorsal aspect, you follow with the reamer, then the screw. This is two images I have taken for dry specimen that I have, and this actually shows you that the scaphoid lies on the AP at almost 45 degrees, and on the lateral again at almost 45 degrees. So with flexion, this may lie vertical in case the forearm is horizontal. And this is what's done, and what I'm using actually is the when you put the wrist in flexion, you put the hand in ulnar deviation, you will have the both ends of the scaphoid lying on each other like this here, almost a ring in a ring, and then the wire will go well in the center under the control of image intensifier, as you see in this illustration here, and then easily you can pass your screw. And this is a magnified picture. So this is a delayed union in a 38-year-old man, done in our institute, and he was kept for a while in plaster, but actually it didn't heal, as you can see. Still good alignment of the scaphoid, no displacement, and also I would say no collapse. And here under the image intensifier, we pass the wire through dorsal approach through the proximal pole of the scaphoid down to the distal one, followed by reamer. Then you pass the compression screw, which is Herber type here actually. And this is the after we finish the operation, and you can see that the screw lies very nicely in the bone along its longitudinal axis, whether on the AP or on the lateral view. This is another man who's 18-year-old, as you can see, was written on his X-ray, and he had non-union of the scaphoid, and you can see the wide gapping here. And actually, we did the same technique through percutaneous screw fixation through the dorsal approach. And this on the AP, and this is the lateral view. And this is after complete union of the fracture and nice alignment of the screw. And you can see here how small the incision which was done on his wrist for the percutaneous fixation. And of course, it should run longitudinally to avoid injury to any of the structures. Most of them run longitudinally as well. And this is a delayed union in a 32-year-old man. And yet, actually, the scaphoid is still nicely aligned. It's not collapsed. And we believed in that time that percutaneous dorsal fixation should be okay. This is the operation done. It didn't actually come very much from the proximal pole of the scaphoid, but I believe still quite satisfactory fixation as seen on the AP and on the lateral view. Again, you can see the scaphoid lies at 45 degrees to the longitudinal axis of the radius. And this is the man. You can see the small incision which was done, and he is doing quite well, almost full flexion here and near full extension, or I would say full extension, and he is quite happy with the result. So, in conclusion, the percutaneous dorsal headless screw fixation of delayed union or non-union of scaphoid fractures is an effective and reliable way of fixation. Thank you.